shape. Okay. Well, now that we've overcome technical problems, maybe it's a sign that we should be careful about renaming this disorder. This talk actually it's very unusual for me to give a conceptual talk. I usually talk about my data. And I will talk a little bit about my data, but the kind of talk I usually give will be buried in a small part of this talk, because I really thought that where my thinking is in this disorder is really a conceptual reframing in my own mind and the decisions I'm making about the direction I want to take my next research endeavor. And it comes out of the thoughts come out of a conversation that's been about a 2-year conversation with Dennis Charney, and it has been shaped also by conversations with Joe Treewasser, who's here in the audience. So Dennis challenged me. I work with him closely, and he challenged me because he acknowledged when we first began to work that he wondered why I spent my time studying borderline personality disorder, because it's a disorder that he wasn't convinced really existed. So, and I think to be fair to him, he was challenging me to convince him. And the product of this is a manuscript that we're hoping to submit imminently, which he very much is happy at this point to put his name to, but that's the background, okay? So why is it important to study this disorder? Of course, it's important because it's a prevalent disease. I don't think I need to say to convince this audience of that. There are a paucity of effective treatments for this disorder, and there are serious and important public health consequences. All of those things make it important, but I think it's also important, and the focus of this talk, in my mind, comes out of why is this disorder so severely stigmatized among mental disorders. I think the sources of stigma come from a few areas. One is that there are doubts about the validity of the disease, which is what I was hearing from my dean, Dennis Charney. I think also because of the complex nature of the disorder, it's hard when people say, I tried to describe to my children what it is I study, and they understand what it might mean to say somebody's depressed. They understand if I talk about people hallucinating. It's harder to describe what's wrong with what happens with people with borderline personality disorder. I think it's also the relative refractoriness to treatment, which leaves people treating borderline patients feeling helpless and that they don't know what to do. I think it's also fair to acknowledge that interpersonal disruptiveness, anger, and difficult relationships is part of the disorder, and so it makes it harder to form a therapeutic alliance. Those people usually work hard to find a therapist that they're comfortable with, and it usually takes time and many efforts. And I think also, frankly, that the name really poorly describes the disorder, and that is one of the reasons we need to change its name. I think the consequences of the severe stigma arise because people generally, psychiatrists in the general practice do not give this diagnosis to patients. They often think it, they sometimes write it, they very rarely share it. And the consequences of that are that patients are then deprived of information about the prognosis of their illness, their families are deprived of information about proper treatments, and I think people are often left for a very long time not knowing what to do. I spent some time looking through yellow tomes that are unavailable now on the DSM-1 and the DSM-2 and very old texts to try to understand where this name came from. And I won't go through this history in painful detail, but will tell you that it was coined by a psychiatrist here at Mount Sinai named Adolf Stern in 1938. And he talked about it as a disorder in individuals who are on the border between neurosis and psychosis. Part of the problem with that idea is that comes out of the psychoanalytic concept of there being distinctions between neurosis and psychosis. And I think, by and large, people are not comfortable with the framework that now makes that distinction. I think the psychoanalytic concept of the ego, the id, and the superego, and the way they relate to one another and what that means about neurosis and psychosis no longer really informs the way that we think about what makes somebody psychotic or not. And certainly, and to some degree about neurosis, maybe more so. But in 1941, Zilberg described the disorder as a mild version of schizophrenia, and Helena Deutsch talked about an as-if personality. And these are patients who she said over-identified with people upon whom they depended. I think there's been a long history of confusion about whether this disorder is describing, whether the name borderline personality disorder is describing schizotypal personality disorder, as we would now call it, or borderline personality disorder. Schizotypal patients have a set of symptoms that look a little bit like schizophrenia. It runs in the family of schizophrenia. Larry Siever certainly pioneered work in schizotypy, showing it's in the family of schizophrenia. And for many of the early studies in borderline personality disorder were in fact studies of schizotypy. It was not until the late 1950s that it was described as a personality disorder. And finally, really, the first empirical work on this disorder was done by Roy Grinker, who was a neurologist and psychiatrist, who studied a group of patients who were not psychotic, not using drugs, were diagnosed as borderline, and were on his unit. And he actually began to characterize the disorder, and he is the first person who identified emotional instability as a core feature of this disorder. Dr. Kernberg in 1975 went on to conceptualize the diagnosis of borderline personality disorder as a diagnosis really of primitive defenses. So this is once again using psychoanalytic concepts to describe behaviors, but he focused on the pathologic object relations and the interpersonal deficits. And I think finally, I think our contemporary diagnosis of borderline personality disorder was made by the observations of John Gunderson, whose work informed and basically started the contemporary diagnosis, which was in DSM-3. And he described 5 domains of functioning: social adaptation, impulse and action patterns, affect, psychosis, and interpersonal relationships as the domains of dysfunction that underlie the disorder. But there is a lot of confusion because the idea of borderline personality disorder, one can understand schizotypal personality disorder as a disorder on the border between one thing and another. It's on the border between the frank psychosis of schizophrenia and of healthy, normal thinking. It's not obvious what the diagnosis of borderline personality disorder as we contemporarily think of it. It's on the border between what and what. It's not clear. I will raise another confound in the whole notion of what this diagnosis is by raising concerns about what a personality disorder is. I think Dr. Soloff alluded a little bit to the idea that we have to think about axis 1, but we're talking about personality pathology. I would like to challenge the field to consider whether we have a bright distinction between axis 1 and axis 2. Personality disorders, as they're currently described, are enduring patterns of inner experience and behavior that deviate markedly from the expectations of an individual's culture, are pervasive and inflexible, and have an onset in adolescence or early adulthood, are relatively stable over time, and lead to impairment and distress. My concern about this is that many axis 1 disorders meet these criteria. I mean, schizophrenia clearly is a disease which carries with it an enduring pattern, pervasive pattern of behavior that's often inflexible. It's a chronic illness with its onset in early adolescence. And I would argue that there's no obvious reason that schizophrenia wouldn't be characterized fully as well by the description in the current DSM-4 as a personality disorder. It's also true that borderline personality disorder is chronic, but major depressive disorder is also chronic. There are many, many diseases, anxiety disorders, PTSD, many disorders which carry with them many intermorbid, between episodes of illness, their people do not come back to baseline, including schizophrenia. And even major depression, which is viewed as the most episodic of our disorders. In fact, there's morbidity between the episodes. In a paper that Larry Siever and Ken Davis wrote long ago, many of these thoughts have been spelled out more, but axis 1 disorders have also always been viewed as biological, and personality disorders as somehow environmental. But we know now that that isn't true. The science paper by Avishai Caspi showed that people with a certain gene for depression ended up, people with something called an SS, a short allele of the serotonin transporter, are thought to be at higher risk for depression, but that only shows itself when they've had early life stressors. So major depressive disorder, as shown very well empirically by Caspi, is a gene-environment interaction. And it's quite clear that there's a gene-environment interaction also for borderline personality disorder. So the bright distinction between a biological and environmental disorder clearly makes very little sense at this point. So these are criteria that Robbins and Guzet have delineated. I thank Joe Treebwasser for his guidance in organizing this by suggesting I look to this. As what are the validity criteria for a psychiatric disorder? They gave 5: careful delineation of symptoms, information about the course of an illness, evidence of family clustering, predictable treatment response, especially to somatic treatments, medications particularly, and biological markers. So I'm going to go through what I think are what we know about borderline personality disorder with respect to these 5 criteria and what we don't know. Now, my talks are traditionally about the biological markers because that's where my studies are. And I will give you some data that's not yet published of my work. Some of it's been alluded to by others, but I felt most of the biological markers have been captured generally by other speakers today. So, what do we know about the characteristics of the disorder? It's prevalent. It's approximately 1 to 4% of the population meet criteria for borderline personality disorder, making it about the same rate as schizophrenia and bipolar disorder. It's heavily represented in clinical populations, and people with borderline personality disorder are disproportionate users of mental health care at all levels, in all levels of mental health care. I think the reason for this is simply we're not as good at treating this disorder. People remain symptomatic because we're not that good at it yet. So people come for help again and again because we're not that good yet at helping people go into remission. It's important to, when we talk about the disorder, there's a lot of discussion about whether we should be thinking biologically about dimensions or not, or the uniform disorder. And I have been raised in the environment where we should be thinking about dimensions. But I did turn to the literature about the phenomenology of borderline personality disorder to consider, does it exist? I mean, I was asked, does it exist? Well, it does exist. Early studies showed that there were 3 predominant factors: disturbed relatedness, behavioral dysregulation, and affective dysregulation that clustered as 3 independent factors that were present in borderline patients that were not present in healthy people, that were quite different from healthy people. And subsequent factor analyses confirmed these factors, but the problem with these factor analyses is when you look at the 3 factors, there's an extremely high correlation, 9.9, 0.94, 0.99 amongst the factors. So that suggests that these things don't separate. While they may look different, they may be present and cluster somewhat differently, they are present in the same individuals to the same level of severity. So they co-vary with one another very well. Subsequent studies also supported a unified construct and showed basically specifically that in a little more detail that frantic efforts to avoid abandonment, although not common in borderline personality disorder, was absent in a non-borderline personality disorder control group. It was also stated that particularly affective instability was highly informative for the BPD diagnosis. But I would say to you that the factor analyses, which have looked at large samples of borderline patients, healthy controls, and other personality disorders, have basically delineated these 3 factors, but they go together so intensely that I would say that we could argue that there is a unified construct that is borderline personality disorder. These things run together in people, and those people have the disorder we're talking about. So what do we know about comorbidity? We know that axis 1 disorders that are most commonly, there's a large study called the Collaborative Longitudinal Study for Personality Disorders, the CLIPS study, that really is at this point I view as led by McLean in Boston. The axis 1 comorbidities that are commonly seen are PTSD and substance abuse, but there's a very, very high rate of major depressive disorder lifetime in patients with borderline personality disorder. However, it is not higher than the rate in other personality disorders, so it is not specific to borderline personality disorder. So recent data has shown a moderate increase in bipolar 1 and 2 within borderline patients, but borderline personality disorder doesn't particularly run in families with bipolar disorder. And I think it's a distinct, people have argued over time that maybe this is really a form fruste, a kind of rapid cycling bipolar disorder. I think the evidence suggests that it isn't because of the fact that the families don't run together, so this borderline and bipolar disorder don't tend to run in families. And also treatment with antidepressant medication in borderline patients tends to lead to stabilizing of mood, whereas treatment in bipolar patients with antidepressants leads to instability of mood and often an outbreak of mania. Our data, our own studies from our own work that Harold Koenigsberg and Chantal Henry have done suggest that affective instability and the particularly anger subscale of the affective instability distinguishes borderline patients from other personality disorders. So that's a finding from within our study, looking at what factor particularly distinguishes other personality disorders from borderlines within our group. I'm not sure how helpful this is, except to say that in arguing whether this is a mood disorder that fits either this is just a kind of odd major depression or a rapid cycling bipolar, I thought it might be helpful to look at certain features that show that borderline personality disorder is distinct. So borderline personality disorder emerges, in my view, in childhood. Major depression can emerge any time in life, most commonly in the second to third decade, and then again a peak in the late life in geriatric phases. Bipolar disorder is in late adolescence. I'm sorry that kind of fell into the next row. Borderline patients are more commonly female. Like major depression, it's an overwhelming, there's a higher incidence in women than in men, whereas in bipolar disorder it's even. So essentially, if you look at familiality, bipolar does not run with borderline personality disorder. People with borderline personality disorder are more likely to have family members who have major depressive disorder. And I think we have very little evidence from people with depression about whether their family members have borderline personality disorder because it just hasn't been studied. People who study depression don't tend to even acknowledge the existence of borderline personality disorder, so we just don't know. Anger is an important part of bipolar and important part of borderline personality disorder. Mood instability is obviously shared between bipolar and borderline personality disorder. The comorbidity is increased amongst all of these disorders. And I think they have different responses to antidepressant medication. So I would actually say that my conclusion is that borderline personality disorder is neither major depressive disorder nor bipolar disorder. I actually think of it as a novel mood disorder. So what do we know about the course of the illness? You've heard today that the suicide rate approaches 10%. 75% of individuals diagnosed with borderline personality disorder make an attempt at some point. There's a lot of other morbidity and difficulty that is associated with borderline personality disorder. But the good news is Mary Zanarini's study, which is a naturalistic long-term follow-up, is in her 10th year now, has suggested that actually there's a relatively high rate of remission over a long period of time. So that's a better prognosis than people had originally thought. There are particular prognostic factors that are likely that make a prognosis a bit better. Younger age, the absence of childhood sexual abuse, the absence of a family history of substance abuse, the ability to keep a job, the absence of a cluster B anxious cluster personality disorder, and other personality features. It's important to state that in Mary's study, remission is viewed as no longer meeting criteria for borderline personality disorder. It doesn't mean that the patients she studied over time don't still require mental health care. They still have some symptoms. They're just not as severe, and they don't reach threshold to meet criteria for borderline personality disorder. Christian talked somewhat about trauma in borderline personality disorder. It is clear that there's a high rate of physical and sexual abuse in the borderline populations. And Mary Zanarini argues that it's almost ubiquitous to have some form of child abusive experience in borderline patients. I have to say, I've spent a lot of time now dealing with trauma and PTSD. And actually, if you ask a healthy population about some form of abuse, if you include verbal abuse, neglect, physical abuse, and sexual abuse, it's extremely common for everybody to have a history of some child abuse. So the healthy population hasn't really been well included in the studies. When you include all forms of abuse, I think we need to delineate specifically what's happened a little more clearly when we look at that. I've been astonished to learn how prevalent abuse is, at least in the United States. So people have viewed borderline personality disorder as being by necessity the result of a traumatic experience, to the point where there were, recovered memory, lawsuits. Basically, there were therapists who were saying if you have borderline personality disorder, you must have been abused. There was a lot of hypnosis and effort to discover abuse that wasn't remembered. And actually, there were lawsuits against therapists ultimately for doing this kind of treatment. And the APA has taken a very clear stance on this, that this kind of recovered memory therapy is not acceptable. And there was a lot of evidence that, in fact, there are many people with borderline personality disorder who do not have childhood physical or sexual abuse. A large meta-analysis looked at the relationship between borderline personality disorder and childhood sexual abuse in over 2,000 people. And while there was an increased risk of childhood sexual abuse in borderline personality disorder, the effect size was very small. In other words, yes, it's an increased risk, but it's only a very modestly increased risk. So it can't be the whole etiology. If there was a direct cause between childhood sexual abuse and borderline personality disorder, we'd have to see a very large effect size. I mean, if it were fully accounted for, we'd see an effect size of 1. But we don't, of more than that. We'd see a huge effect size. We see nothing. So the effect size is very small. So childhood abuse in borderline personality disorder, I guess we can say, I'm trying to make the point that it is prevalent but not universal. 20 to 40% of people diagnosed with borderline personality disorder do not report a history of childhood abuse. And conversely, 80% of individuals with a history of serious childhood abuse that's been documented and reported do not end up with personality pathology. So the causality is not tight. I'm going to skip this. This is a smaller study of ours that basically shows the same thing, that there's an increased rate, but I'm not going to go through that in particular. I think I've made these general points that essentially there are many possible sequelae of childhood sexual abuse. Some people, there's actually very interesting work being done by Kathy Spatz-Whittam, who's followed a group of kids who reported for serious abuse when they were young, and she's followed them longitudinally, and a significant proportion of them actually have no psychiatric sequelae at all. They're what I would term resilient, and she is only just beginning to look at the data, whether they have emergent borderline personality disorder. That was not part of her original assessment of these children, unfortunately, although she has measures to try to approximate that. But there are many other consequences, obviously PTSD, substance abuse. There are many other consequences to childhood sexual abuse, which basically, I think, undercuts the notion that this is a disorder fundamentally that is the result of trauma, per se. So you've also heard today that this disorder clusters in families, that it's an inherited disorder. So what are the data to show that? We know that borderline personality disorder runs in families. First-degree family members of borderline patients are more likely than other people to have borderline personality disorder. Particularly, they're also more likely to have components, dimensions, to have what would be potentially viewed as a borderline spectrum disorder with affective instability or impulsivity. But the fact that family members tend to have borderline personality disorder in the probands, the family members of probands, doesn't separate nature from nurture. The way to do this is to calculate a heritability score, and the way to do that is to use twin studies. And twin studies essentially calculate the component of the symptom that's viewed as heritable by looking at identical twins and comparing the degree to which they share. I mean, when there's something called concordance, which is if you're looking at do they or do they not have borderline personality disorder. Concordant twins would be those who have both have the disorder or both do not have the disorder. And non-concordant would be those who are different. One has, one does not. And when you look at concordance rates between identical twins and compare them to non-identical twins, you can calculate a measure for the degree to which the genes account for the outcome. The genes account for the diagnosis. The way you can do this is because obviously identical twins are genetically identical. They're actually more identical than what everybody gets all anxious about cloning. Clones actually are less identical than identical twins because they don't share mitochondrial DNA, but twins share all their genes, and obviously non-identical twins share on every half. I mean, they have a parental gene from both sides, just like siblings do. And so essentially what we know is that the studies show approximately 60 to 70% of the heritability of the variance predicting borderline personality disorder is accounted for by genes. Heritability scores of 0.69, 0.60. These are the kinds of heritability scores we found. And an additional 10% of the variance comes from common environmental factors. So I think we know that it's a pretty heritable disorder. And so I think that gives really a lot of importance. This is really probably one of the most important findings that suggests this disorder exists. It is a disorder that is coherent. There's one essential construct, and it is a disorder that runs in families and is highly heritable. So this goes a long way towards establishing that the diagnosis exists. So why is it doubted still? I mean, part of the reason it's doubted is because not everybody reads the literature on this and knows this, not all general psychiatrists, but also because I already talked about the Caspi study, but also because of the next component, which is predictable treatment responses especially to somatic treatments. And there have been at this point a lot of pharmacologic trials in borderline personality disorder, some of them quite promising. Mary Zannarini studies in particular have shown that olanzapine can be helpful. Olanzapine and fluoxetine together are helpful. Fluoxetine alone is helpful. But the effect, there isn't a robust effect. And you don't see a robust remission of symptoms. You see a slight improvement on particular dimensions. And so I would say, having done these studies and talked to people who do these studies, we're often looking for the effect because the markers that we see are all over the place. We measure, what happens is we invite people to come and participate in our studies, and we're very grateful when they do. And we give them the medication or a placebo, and we measure a variety of symptoms. And we ask them to come in every week, and they come in every week, and we measure them, we ask them the same questionnaires. And one of the things that's frustrating, this is true of all of us who've done these studies, is that the findings are all over the place. People go up and down, and we always say, oh, well, I know that's a problem because they had a fight with their partner, this bad thing happened, they don't like the research assistant, something happened. There's an interpersonal interaction that basically colors the weekly scale, so we are all over the place. Another problem we've had in our studies is when we look at pharmacologic outcomes, sometimes we have trouble assessing people. For example, we're looking at aggression. We have trouble assessing people's aggression because basically sometimes they're so severely afraid of their anger that they stay in their apartments until week to week. So they have absolutely no interactions with anybody until they come to us. And that becomes a problem for us to assess because they basically can't report on, they've isolated themselves so completely. So basically, I think it's very hard to get predictable and reliable outcomes in borderline personality disorder with the traditional pharmacologic studies. I think it's important that we acknowledge this because I think the other thing about the somatic treatments is that generally, biological psychiatrists have used information. The brain is a complicated organ, so we're often at loose ends. We have very good technologies, as Paul says, but we actually don't understand what they mean all the time. And one of the simplest ways to understand what a mental disorder is, and very much used since the beginning of biological psychiatry, is reliable response to a particular treatment in a particular disorder suggests that whatever you're doing to treat people is somehow targeting that disorder. It's very simple. That's how we came to dopamine in schizophrenia. That's how we came to norepinephrine and serotonin in mood disorders. It's very straightforward. The problem for us with borderline personality disorders, no medication is very robust, and a wide variety of medications work with no one particular mechanism. So we're left in the dark to a certain degree. So the problem of our having no robust somatic treatments is a problem in part for all the patients that we aren't really able to help with medications. And the other thing, so we fail in that regard. And the other is, of course, we're left without a clear mechanism to investigate because of we don't have a clear, simple biological response to a medication that can allow us to say, oh, if this thing works and this thing works on the serotonin system, it must be about serotonin. We are left without that information. And I think the other important thing is what I was describing, which is it's also hard to know whether medications work because there's so much noise in the system when you assess a snapshot in time in a week. For somebody who's very affectively unstable and very interpersonally reactive, when you assess them for half an hour a week, you may really not be getting the information you need about how their week has been. So there'd be a couple of ways to go about trying to figure out how we could do this better. One would be to ask somebody they live with to tell us how has the week been. That would help. I think sometimes people would find that intrusive, and I don't want to ask my spouse or my friend to come and tell you how I've been. And I think that's a privacy issue that would only be available as an avenue for people who felt comfortable enough and trusting enough in one individual to be willing to do that. Another strategy is to do event contingent recording, which is a technique that's been developed at McGill. And I'm going to say the name. Mariah has just told me Moscovich. I always say Moscovich, who has developed it. And there was actually one very interesting study showing that this event contingent recording is plausible in borderline personality disorder. So what is event contingent recording? It's a naturalistic way of looking at interpersonal interactions by giving people pieces of paper to mark every interpersonal interaction up to a certain number a day, and asking them to rate things about the interaction. And there are a series of very well-validated questions, and they rate both specific components that I'll describe about the interaction, and they also rate many of the ways people have done this include questions about how they felt about the interaction and whether they felt satisfied, angry, pleasure, and various things about how the interaction went. But the particular domains that have been assessed are along two dimensions, agreeableness and quarrelsomeness, and submissiveness and dominance. And so actually this just came out probably in the past maybe month that it's been available in a published manuscript by Jennifer Russell, and showed essentially this is a way of characterizing the interpersonal interactions and how people felt about those interpersonal interactions over a period of time. Now, the study that was done here involved 20 days, where you get a picture of how people have been in their interactions over a 20-day period, which may represent a much better sample of how the person is doing than the half hour they come in when they may be in the throes of an affective episode. So what she showed is that essentially that borderline patients, in contrast to what we might think, do not have particularly unstable negative affects in response to interpersonal interactions. They have consistently negative response affect after interpersonal interactions, but they have rather unstable positive responses. So some interpersonal interactions are positive and some are not at all positive, but all of them have an element of negative. So it is an interesting thing that if you look at the valence, essentially there's a consistently sort of low affect and sadness after interpersonal interactions, and there sometimes is an element of joy. So the paper's interesting. I recommend it to you. It's in the Journal of Abnormal Psychology. But I think what the point of my raising it here is that it's a technique that can be used in borderline patients, and maybe a technique that reflects better pharmacologic studies and outcome than we've previously had. So I'm going to also suggest that one of the reasons that we haven't been very effective in treating borderline personality disorder and tracking the pharmacologic outcomes is that we've missed the effect on the interpersonal. Essentially, I would argue that we've completely overlooked the interpersonal dimension when we deal with patients, and it is the elephant in the room. Everybody knows people who have difficulty in interpersonal interactions. So I think it's important to say something about why. What do we know about the social cognition? It's becoming a hot area. I would acknowledge that Paul Poconis has just done some interesting work on interpersonal interactions, and I know it's a great interest of John Gunderson's now as well. But essentially, one possibility that was raised in Harold's talk is whether whether one of the features that's a hardwired early feature of borderline personality disorder is an overreading of negative affect in others. So the studies we know show that an early study, relatively early study, actually from Marshall Linehan's group, showed that women with borderline personality disorder identified fear and angry faces more accurately than controls, but they also misread what were neutral faces, overreading anger. In a recent study by Tom Lynch that I alluded to earlier, in using an interesting technique, the multimorph facial affect recognition task developed by James Blair, was that he basically he developed a technique where he took standardized, clearly validated faces that were angry and fearful and other things, and then had the same model have a neutral expression. And he showed that you take from full anger to neutral over 2.5% gradients, and it changed slowly. Actually, it changed from neutral to the affect. And so the subjects had to press a button when they recognized the affect and then state what the affect was. Healthy controls did this pretty well. Borderline patients did it better. They actually recognized the affect accurately, and they recognized it at an earlier morph than healthy people, suggesting that the gain is such that borderline patients are not, misreading or reading wrong. They're just reading way too much. They have a lot of noise coming at them of negative affect all the time. And another piece of evidence that suggests this oversensitivity to negative affect is an earlier study of Donegan's that from Yale showed that borderline patients hyperactivated the amygdala to fearful faces, but they also hyperactivated the amygdala to neutral faces, and there was no effect of the valence of the face. So this would suggest, again, they were overreading neutral affect, but maybe we as healthy people who aren't diagnosed with that, whether we're healthy is another question, but people who are not diagnosed with borderline personality disorder are underreading. I mean, maybe those neutral faces were not pictures that were actually neutral. Maybe those people were a bit annoyed, but we see it as neutral, and people with borderline personality disorder see it as fearful. And in fact, the Lynch's study would suggest that. We did a recent study of Michael Minzenberg showing an overactivation of the right amygdala in fearful over neutral faces, which suggests a fear over neutral specifically. And Michael did a morphed face task, so he was able to show that in response even to 50% morphs, there was a response of borderline patients to fearful over neutral. So even at subliminal faces, that was there. And that's no longer in press. It's published already. So one point that I wanted to make related to what we were talking about earlier is, well, so what happens if this is true? And one thing I would say is that if you start your life overreading negative affect, it makes it harder to self-soothe. So if you are, I can tell you I'm a mother of 3 girls, and it's very common for me to come home from work stressed and annoyed, and my girls probably read that affect. But if they read that affect at a hyper level, they might personalize that affect, and even where it's unintended, the ability to absorb negative affect around you as a child, even if it isn't directed at you, even if it isn't overt abuse, may make it harder for individual children growing up and developing borderline personality disorder to be soothed. And so I think it's important that we consider if this is one of the core abnormalities of this disorder, it's almost certainly present from birth. And if that's true, and it may, and it's an empirical question we need to ask. It's an empirical question about whether the overreading of negative affect is related to being depressed at a certain point. But we don't see that overreading of negative affect so much in depression. We see it particularly in borderline patients. And so the question, is it about affective state, or is when you help people who are borderline who do not have depressed feelings anymore, is that still present? Is this an underlying stable trait? And the answer is we just don't know yet, and that's an open empirical question. So I raise this as not it's just a potential model, because it does, one has to consider that if, that there's a corollary of the idea that this is fundamental to borderline personality disorder, and that is that whether patients with borderline personality, many of them have been neglected, but in fact, if they're picking up negative affect a lot, the effect may be that they are in an environment where they do not receive the self-soothing and are effectively neglected, even if their external environment isn't neglectful. So that there may be what we would call in medical terminology phenocopies, people who have a genetic, where there are a number of genes that undoubtedly underlie this disorder. If the vulnerability is great, even with the most supportive environment in the world, if you actually can't receive that support and overread negative affect, it may effectively feel like neglect. Then there are clearly going to be people who, even with less genetic proclivity, who have actual serious abuse, may also end up in this looking very similar. So this is sort of just a theoretical consideration about what might be the reason that there's a fair amount of trauma, but because we may be looking at 2 different pathways to arrive at the same disorder in the end. So now I realize that I'm at the very end of my time, I think. Is that correct? So what I'm going to do is not go through the biological markers, because I think those things have been relatively considered by other people. I would show you, the quick and dirty statement is that we have evidence that, I have a PET study I'm working that is in preparation now, showing essentially, much like we've seen earlier and much like Paul's work, that in a resting state, my borderline patients had a very low prefrontal intercingulate and orbital frontal activity, and that when they were provoked to anger, they actually looked more like healthy controls. But the resting state of being sort of out of it was actually dramatically low, and similar, the amygdala and prefrontal cortex were down. So that sort of suggests that there's a tonic level of low orbital frontal activity in our PET study. So that was what I was going to tell you, and that will be online as a published manuscript before long. What I'm going to actually do, let's see if I can make this, I'm going to try to go to my slide at the end, which thanks people, because I'd like to do that. If I can make this is not a great mouse, I'm afraid. Let me see if I can go to the end that way, because the mouse won't do it. So I will say that my talk is really a couple of things. Shall we rename this disorder and place it on axis 1? I would argue that there's abundant reason to rename it. I'd argue that it's a clear disorder. The renaming of it is complicated because, there's all this work done, and we all know what borderline personality disorder is on some level. But I do think the name adds to the stigma and is very confusing, and I think it's an unfortunate name. I also think we have every reason to believe this is an inherited disorder and that there's going to be a complex neurobiology that will be elucidated. And yes, the neurobiology is not yet understood, but that's true for every mental disorder we have. We do not understand the neurobiology of depression, PTSD, schizophrenia any better than we understand the neurobiology of borderline personality disorder. And I do think that the idea that this disorder should be on axis 2 leaves it incredibly stigmatized and probably even more importantly not covered by health insurance in the same way that other disorders are. And I think that's a terrible problem. So I propose just my idea, interpersonal emotion dysregulation disorder as a novel, as a way of thinking about this disorder, but I'll leave that up to you to describe. I'd like to point out, these are my colleagues who've worked with me on this idea. And finally, if anyone would like to give us a call, this is where we do evaluations. This is our telephone number, and I'll leave that up. Thank you. Oh, Larry, you don't want to do this? Okay, I'll do it. Okay. Is there any research of people overreading positive affect? There is no research, and it is something I'm beginning to work on, but there is none. And I think it's an important question. I think it's a hugely important question, and I think the question I asked Dr. Schmal after his talk was if people with borderline personality disorder, he's studying fear conditioning. I wondered if he's studying reward conditioning, because I think almost nothing is known about the way patients with borderline personality disorder manage positive affect. I really have to say we know almost nothing, and it's a hugely important question. So hypersensitivity, I can't read this. Milo environmental disorder, I can't read it very well, but I don't have my Milo environmental disorder. There you go. Larry, I'm going to let you take these, and you can make your choices of that.
Well, one question is it premature to consider a new name given the early interest in DSM-5 that would combine all personality disorders, or do you see BPD going to axis 1 as a separate condition?
Well, I'll give you my view, which is that I think there are two disorders on axis 2 that should be on axis 1, and they are schizotypal personality disorder and borderline personality disorder. I think it makes zero sense that a schizophrenia spectrum disorder, which is genetically linked and familially linked, treatment response linked to schizophrenia, is an axis 2 disorder. So I think that schizotypal needs to be moved, and frankly, I think so does borderline personality disorder. And I think the other disorders are much less well known, much less well understood in many respects, and I'm not opposed to the idea of them being clumped as a group and with dimensions.
I guess a related question is, should BPD be considered on axis 1 as an anxiety disorder or a mood or affective disorder distinct from MDD and other specific anxiety disorders?
I argue this is a manuscript in preparation that's about to be sent out. I think it's a novel mood disorder. I do think there's anxiety, and in other axis 1 disorders, major depression, there's a fair amount of anxiety. In anxiety disorders, there's a fair amount of depression. So those things are not pure and distinct. But I think that the mood disorder is a more central feature of borderline personality disorder. So simply trying to cut it in terms of where it falls, I personally think that we see a lot more mood symptoms. Yes, you see panic disorder occasionally, you see generalized anxiety, but I think you see more dysphoria and sadness.
Is there a specific treatment to change this overreading of negative affect, either in medication or talk therapy, that would help someone with BPD relearn how to self-soothe?
I think it's an open question. I would love to hear people's thoughts. I think that's some of how DBT works. I think that's part of what the skills training is about, and I think one of the difficulties is getting people to, I think you have to, DBT works when people are willing to engage in it. It's not always so easy to get people to really engage it, but I think once people are fully engaged in DBT, I think the skills training probably has an effect. but I don't think it's explicit enough. I think if we discover empirically more information about this, I think we ought to tell people that this is a problem they have and teach them more explicitly. But that's potentially a revision of the skills training component of DBT.
Has anyone studied borderline in the concomitantly blind, where there's no hyperactivation of visual cortex and amygdala?
That's a very interesting question. Nobody has studied it. I have to say that's the question my husband asked me when I was talking about this with him. I don't think it's purely about visual stimuli. I think it's all kinds of stimuli, and I think that's what we've studied because that's the easiest thing to study. But I think that people pick up affect. I mean, it's complicated how blind people pick up affect, but they pick up affect through intonation of voice and content. And it is my impression, but I have really, this is really winging it. I would doubt that it's just about visual affect, but nobody studied it at all. There's no empirical data. Does anyone know anything, any empirical data on that? I know nothing. Oh, that's interesting. Well, there are, yes. Yeah. Yeah, I mean, that's an interesting, there is something about distorted interpersonal relationships per se that I, have read a little bit about, but it would be a really interesting thing to look at picking up vocal affect, for example. And I don't think there's been nothing done on that I know of.
Maybe one more. How do you think we can reach the APA DSM-5 committee to change BPD axes as they have ignored us for years?
I think my first answer is I don't know. My second answer is that I worked very hard to have a publication with Dennis Charney as a senior author because he's really outside of this field and he really supports this work, and I think that's helpful to the field. And that's frankly part of the motivation for my paper. So.
Okay, thank you, Antonia.